So with that, I'd like to introduce our first speaker. It will be Dr. Mark Adams from Rutgers University and University Hospital there. He will be speaking to us on the radiographic evaluation and classification of pelvic ring injuries.
So pelvis radiographic evaluation and classification. When I'm finished with this talk, I would like you to be able to describe what makes for quality pelvic radiographs. On these radiographs, I would like you to be able to visualize the bony structure they represent and describe the relationships between certain bony structures and the adjacent neurovascular structures. There are relevant associated injuries and issues that are apparent on imaging that I would like you to identify. Lastly, I would like you to be able to use the classifications to describe the injury accurately and, as a result, guide treatment and predict associated injuries. The experts that evaluate money to determine whether or not it is counterfeit, when they're in school, they study the intricate details of the real thing, not the fake. Similarly, we will study normal anatomy to start so that the issues that arise from disrupted anatomy become more obvious. When we look at this, we want to be able to picture the skeleton it represents, but also this. In our mind, be able to picture the muscular and neurologic anatomy and their relationship with the bone, as well as the vascular anatomy of the pelvis. Understanding these relationships helps us anticipate injuries to these structures when we examine a radiograph of an injured pelvis. The AP pelvis is generated with the patient in the supine position. The beam naturally is perpendicular to the patient. A well-centered AP pelvis anteriorly consists of symmetric obturator foramina, symmetric teardrops at the bottom of the fossa, a symphysis that is midline with respect to the sacrum. Posteriorly, the spinous processes of the sacrum should be midline, the foramina should be symmetric, and if there is no scoliosis and the patient is lying flat, the similar lumbar spine features are helpful too. In the setting of a pelvic ring injury with deformity, one needs to key in on the posterior structures to know whether or not the film is well-centered. It is difficult to characterize deformity without a well-centered image. The outlet view is an AP of the sacrum, seeing it en face. As such, the foramina are well visualized and circular in appearance. Many of the same characteristics of a well-centered AP pelvis are also applied to the outlet. Let's notice the intimate relationship between the L5 nerve root and the sacral ala. The S1 nerve root is also visible, coursing out laterally from its foramen. The internal iliac and its branches are also in close proximity to the lateral sacral ala, and the median sacral artery is adjacent to the sacral bodies in the midline. More anteriorly, the external iliac courses over the anterior pelvic ring, just medial to that iliopectineal eminence. The inlet view is relatively orthogonal to the outlet, viewing the sacral bodies stacked one on top of the other, and needs to be well-centered and symmetric appearing sacrum. Once again, we see the intimate relationship between the lumbosacral neurologic plexus and the anterior sacrum, as well as the plexus created by the internal iliac branches and the external iliacs descending by the iliopectineal eminence again. Naturally, there is the corresponding venous network here as well. It is important to distinguish the dysmorphic sacrum from the normal sacrum and review some of the radiographic features of dysmorphism. The bottom line creating this distinction is that a transsacral screw is possible in the normal sacrum, but not in the dysmorphic. You'll notice that the dysmorphic sacrum has this acute alar slope when compared to the normal sacrum. Furthermore, the upper sacral segment is not as recessed in the pelvis. On the inlet view, we also see a difference at the sacral ala. Radiographically, there is a cortical indentation of the anterior ala on the inlet radiographic view, which is represented with these arrows. To further understand this acute alar slope, we're going to look at the lateral. Note a quality pelvic lateral has overlapping greater sciatic notches and matching iliac cortical densities. This line marks the iliac cortical density. For the osseous fixation pathway and neural tunnel of the first sacral segment of the normal pelvis, I have marked them here. For the osseous fixation pathway and neural tunnel for the first sacral segment in the dysmorphic pelvis, I have marked them here. For the osseous fixation pathway, please note that this does not represent a column of bone that runs uninterrupted from one ilium to the other, like the osseous fixation pathway in the normal pelvis I just outlined. Rather, this pathway is oblique, as we have seen on the inlet and outlet views so far. Furthermore, this osseous fixation pathway in the dysmorphic sacrum cannot run uninterrupted from one ilium to the other, as the majority of this oblique osseous fixation pathway in the dysmorphic pelvis is cranial to that iliac cortical density. In other words, the acute alar slope does not correlate with the iliac cortical density. However, in the normal pelvis, the alar slope corresponds with the iliac cortical density. When we look at the axial CT images of both types of pelvis, we can see that there is an uninterrupted corridor of bone in the normal pelvis that is sizable in width. This same corridor of bone does not exist in the dysmorphic pelvis, however. The posterior line violates the neural tunnels of that first sacral segment. This is why a safe transsacral screw is not possible in the dysmorphic pelvis. Furthermore, with a more anterior starting point, the neurovascular structures anterior to the sacral ala that we just reviewed would be put at risk with a transsacral screw. Chip Rout will further review how to safely execute iliosacral screws later in this session. Now, our natural tendency is to dive into the particulars of the skeletal injury for our patient. But before we do that, our patient's imaging provides a real opportunity to learn about our patient. We're going to go through a few examples just to illustrate this point. The soft tissue windows setting on the CT scan can be very helpful, and I encourage you to use it. In this example, not only would this large fibroid complicate work about the anterior pelvic ring, but this large Morel Lavallée has implications for work about the posterior ring. Sometimes our pelvic ring injuries can show up pregnant. Now on this example, our eyes may be drawn to those cam lesions bilaterally, but if you note, this patient has staples, and those indicate that he had a previous laparoscopic hernia repair with mesh. Conversely, this patient has bowel in his scrotum, fatty atrophy about the bilateral gluteus maximus, and the redundant pliable skin common in malnourished patients. This patient has a right sacral fracture, and it is associated with significant osteopenia in the bilateral sacral ala. Furthermore, there are calcifications in her arteries. Believe it or not, this patient is a 25-year-old, but she is diabetic. And based on what we see here, physiologically, she would be comparable to a geriatric patient. In this example, we see the abdominal wall attaching nicely to the ilium, but on this side, we see a traumatic herniation. Here we see a swollen left rectus muscle, a bladder full of contrast, and there's extravasation on the left and extravasation inferiorly as well. These are just a few examples, but by getting to know our patient in this way, we can anticipate problems early and have comprehensive plans as a result. Now, there are three classifications in dealing with the pelvis: the tile, AO, OTA, and the Young and Burgess. These classifications approach the injury from different perspectives. By combining what we learn from each of them, we can engage a patient's injury radiograph thoughtfully and more completely. They will help us describe the injury, organize our thoughts, and guide treatment. The tile classification approaches the pelvic ring from the perspective of stability, breaks it down into three categories: stable rings, vertically stable but rotationally unstable, and both rotationally and vertically unstable. In terms of guiding treatment, patients with unstable pelvic rings are indicated for surgery, and those with stable pelvic rings are not. Classification by Young and Burgess is based on the presumed mechanism of injury. From this, we are able to predict associated injuries and resuscitation requirements. The Apc injury is a volume expanding injury to the pelvis, tearing that vasculature that we reviewed earlier, and can have significant bleeding as a result. Hans Krieter will go into depth on this next. The lateral compression injuries are associated with head injuries. Now, the OTA-AO classification takes a more anatomic approach to the pelvic ring injury, but also include reference to the type of instability pattern, like in the tile classification, and labels certain examples with the corresponding category in the Young and Burgess classification. A types have an intact posterior arch, B types have an incomplete disruption of the posterior arch, and C types are complete. Thus, there is an increasing amount of instability through the classification. This classification also includes a description of the deformity produced, which helps guide treatment. Whatever the deformity is, it needs to be reversed in order to obtain a reduction. Increasing amounts of instability require increasingly durable fixation constructs to maintain the reduction. Starting with our incomplete injuries, this injury is limited to the symphysis and is rotationally stable as a result. This would be consistent with an Young and Burgess APC 1. Here, the injury extends to the sacroiliac joint, hinging on the posterior ligaments, and the hemipelvis is unstable in external rotation. This is consistent with an APC 2. This sacral fracture is anterior and incomplete, accompanied by an anterior ring injury. This category is rotationally stable and would correspond with an LC1. Here, we have an increasing amount of injury to the sacrum on the bottom image, creating instability. Although this fracture of the ilium illustrated is technically complete, it is classified as a B due to the presumed rotational nature of the injury. Naturally, this hemipelvis will become vertically unstable as well due to unopposed muscular forces. There are bilateral versions of these incomplete posterior ring injuries as well that are in the B category. The C types. Our complete injuries are more severe injuries in the same anatomic locations, with increasing amounts of instability and cranial displacement of the injured hemipelvis. This complete injury to the left SI joint with a symphysis disruption is consistent with an APC 3, and this complete cranially displaced sacral fracture corresponds with a vertical shear. Also in the C category are bilateral injuries with one side complete and the other incomplete, as well as bilateral with both sides complete. Now let's apply these classifications. Here, the anatomic sites of injury are to the symphysis and left sacroiliac joint. It is unilateral, incomplete, unstable in external rotation, and has no vertical instability. For treatment, an internal rotation force is necessary as a reduction maneuver to reverse this deformity. As this is an APC 2, the patient is at risk for bleeding. When we contrast this to the previous patient, we see a major difference at the SI joint. It is cranially displaced, which is obvious when we compare it to the other side, which shows the edge of the posterior ilium caudal to the sacral foramen of the second sacral segment. This means that the injury is complete, and that would be consistent with an APC 3 type. For treatment, not only does this hemipelvis need internal rotation for a reduction, but it needs to be manipulated in a caudal direction. As there is no posterior ligamentous integrity, it would likely require a more substantial fixation construct to maintain the reduction than the previous patient with an incomplete injury. Just to comment on the limits of our classifications. Here is this patient's right hemipelvis. Now, although it is true that this is a complete injury through the symphysis and SI joint, to characterize this as an APC 3 would be inadequate, to say the least. This patient has unilateral injuries to the left sacrum and parasymphyseal ramus, which are incomplete, with internal rotation of the left hemipelvis. Discernment of instability in this injury pattern that warrants operative treatment will be discussed in an upcoming lecture. This is in the LC category, and these patients are at higher risk for head injuries. We see an increasing amount of displacement, deformity, and instability in this patient that was T-bone, creating this lateral compression injury. This is a complete injury to the sacrum that is certainly unstable in internal rotation. When we look at the outlet view, however, we see cranial displacement as well due to the unopposed pull of the iliopsoas. Therefore, this patient's hemipelvis needs to be manipulated in a caudal direction and externally rotated force to reverse this deformity and obtain a reduction. So both a caudal manipulation and external rotation. Conversely, this patient jumped off a 3-story building and has bilateral calcaneus fractures in addition to this pelvic ring injury. This is consistent with a vertical shear mechanism, and we see significant cranial displacement of the right hemipelvis through the complete unilateral right sacral fracture. The L5 nerve was injured as a result, which is understandable given its intimate relationship with the bone. Traction will be necessary to correct this cranial displacement. So in summary, we discussed normal skeletal and neurovascular anatomy in the pelvis and corresponded this to our radiographs. We defined what makes for good views of the pelvis. We went through the comparison of normal and dysmorphic sacrum. There are other relevant associated issues and injuries that can be anticipated on imaging, as we discussed. We then reviewed the 3 classifications from their different perspectives and applied these classifications to several patient examples. This helped us describe the injuries, organize our thoughts, predict associated injuries and issues, and also directed us toward the treatment.